Good morning, everyone, and thank you very much for inviting me to come and speak about BPS. My name's Carl Fenwick. I'm a clinical dental technician, and I do a bunch of things. I work in practice. I also work for Biofunctional UK. I'm in charge of the removable side of education. So I do both clinical and technical education courses, and I look after opinion leaders. And I do a bunch of other things around the world. I lecture internationally and teach internationally. So what I'm kind of trying to bring today is to give you guys an overview of the Ivor-Claw-Vivadent denture system. It's been around for a long time, maybe 40 years, something, maybe longer actually. And it's a proven system for clinicians and technicians to achieve success with removable prosthetics. It's arguably one of the most challenging areas, I feel, when you haven't got anything whatsoever in the mouth and you've got to make something which will stay put, function, be aesthetically pleasing, and tick many, many boxes. So it's quite a challenging thing, and I think it's quite underestimated as to the difficulty. So Ivor-Claw have a system which can address each individual part of making a denture, right through from impressions to the final processing. And each part of that system is really geared to give you the most consistent results that you can possibly get. I've been using this system for many years now, as have a lot of my peers. I know Paul's a fan, and that's, I guess, why we're going to talk about it today. So any questions you've got, feel free, put them in. We'll go through them at the end. I should be able to answer most of them, and if not, I'll get back to you with the answers. Okay, so we shall start. So, removable prosthetics. As I mentioned before, there are several steps in removable prosthetics to be successful, and it's quite often easy to skip these steps, particularly time pressures and things like that. But at the end of the day, it's the patients who will suffer, and I've treated enough patients now to realise that the more time you take and the better quality materials and the better the system that you use, you will have a happier patient at the end of that. And that's what we're all after. So I'm a big believer in a systematic approach to anything. I teach digital dentures as well. And a lot of people think digital dentures will fix a lot of the problems that we have with analog systems, but you need a real good understanding of prosthetics. It won't fix bad impressions, it won't fix bad jaw registrations, things like that. And this system will give you a real good basis, and if you learn it and if you become a scholar of it, you will become excellent at dentures. There's no doubt about it. I've taught enough people now the system. I was taught it myself many years ago, and it's time proven. There is no doubt about it, it works. It also forms the basis of the Dr. Arbe technique. Dr. Arbe technique is a development of this. It's all based on BPS. There's myself and another 3 instructors who teach it in the UK, and we all use this system. So it's a very, very important and adaptable system. So as I mentioned, we have our impression materials, which is a virtual. I'll show you a little bit on each of these. We have our jaw registration equipment, which is our Nathometer with Gothic arch tracer and face bow. We'll have our own articulators. We have right up to virtually fully adjustable. We call it fully adjustable, but the Stratus 100, 200, 300. We obviously make our own teeth, very famous for making ceramics and our own denture teeth. We have our denture base material, and then we have our maintenance. Okay, so Servitech gel and liquid for aftercare. So I'll go through and touch on a little on each of these subjects. And it's all designed to make beautiful dentures. But the dentures have to be well-fitting, the jaw registration has to be correct, the tooth position has to be correct, it has to obviously be aesthetic. There's many, many things which go into these dentures to make them successful. And as I say, we have a solution for each individual part. So where did it come from? Well, the BPS system, it basically was born out of the guys in Sean in head office in Liechtenstein, and they sort of had a look at all the masters of removable dentures, Dr. Strack, Giese, Gerber, and they more or less cherry-picked all of the best bits that they thought would be predictable and relatively easy to learn, and then you can put that together in a system and go from there. And once you learn this system, really, I mean, I wouldn't go back to doing regular dentures ever again. I only do these dentures and Dr. RB dentures, the suction affected dentures. And that's the only two methods I use, and they're both heavily interlinked with each other. And I've never had the success with any other system. There are some real good systems out there, but because this has an answer for everything along the way, it's a complete solution. That's how I feel about it. So that's where it came from. And it's all based around Dr. Strack, who designed Ivoclar's teeth as well, some of the teeth. And this is what he said that we need to have in balance, to have a harmonious denture in the mouth. Because if there's one of these factors that isn't correct, it does have a negative knock-on effect for the patient, as we know. You know, the patient's got to be able to do all of these daily functions, they've got to be able to speak, chew, everything else. And if you can ensure that your denture works in harmony with this little diagram here, then you will be on the path to success with your removable dentures. There's no doubt about it. So these are the primary things that this system addresses, and these are the most important things that the system dictates. So what are the steps? So we have a BPS denture. Now normally with regular dentures we have primary impressions, special tray impressions, and we'll have a bite, try and fit. So we have, you know, roughly four appointments. I know we can jump an appointment here and there, but with the BPS, we have more or less the same. It does take a little longer surgery time. However, the fees for these dentures more than compensate for that. And where you really benefit is post-fitting, because when you fit the denture, there's obviously a lot of things that you can then have come back to you, such as sore spots, changes in bite, blah, blah, blah. With this, you effectively only really have to concern yourself with sore spots, and they are a lot less than normal, because when you do this system, you have the teeth in the correct place, you have the bite completely right, you have functional impressions, which is a must in my opinion. So you've kind of like removed a lot of the problems along the way. So you really benefit as well post-fit with reduced numbers of review appointments and soreness and things like occlusal errors, etc. So what do? First appointment, we'll do our primary impressions and eccentric tray. I'll show you that. That goes back to the laboratory. They will make the custom trays and incorporate the Gothic arch tracer. Now the Gothic arch tracer, in my opinion, is the best thing you can possibly use to record a full bite. I use it for partials as well, but it basically removes, if you learn how to use it and interpret the information it gives you properly, it basically removes wrong bites forever. You just won't get wrong bites. There's a couple of patients, Alzheimer's, Parkinson's, things like that, where any bite will struggle, any technique will struggle. But for the vast majority, this will just remove any problems you have with incorrect jaw registrations. That goes back, and we then do our functional impressions and our Gothic arch tracing. That goes to the laboratory. We have the correct templates with the curve of Spey, curve of Wilson, and we use those to set the teeth up correctly. Goes back to the trying, confirm everything is correct, make any adjustments we need to, and then process and fit for the patient. So pretty much the same workflow, not that much different at all. Okay, just a little bit more time taken. But again, you can charge a lot more for these, and you have reduced problems post-fitting, which is what we all want really. So that's the workflow. So our first task is when we get our, our patient in, we need to check what we're working on. And this is really important because the things like flabby ridges and stuff where patients have had a full upper against a lower 3 to 3 for years, and it's basically just rocked and created a flabby ridge. These are really problematic to get a satisfactory solution, because you're basically putting a denture on tissue which has no support underneath it. So there's different techniques you can use to get around that, but we need to know what we're actually working on. So it's important to have a look at the structures that you have to make your dentures. So we check, see what condition our alveolar ridge is in, check any frenums, because quite often they come really high onto the ridges and they can cause a problem, because if they come too high, they can dislodge the denture. This is all captured in functional impressions, which is why it's so important. You don't capture this in overextended, regular special tray impressions. It just pushes everything out of the way. And when you push tissue, it wants to push back. So you can make a denture on an overextended, regular kind of impression, but really what you've done is you've just pushed that tissue out of the way. You make the denture fit that stretched tissue, and then as soon as you take your fingers away, the tissue just wants to push that denture out because it wants to return back to where it was. And this is why functional impressions is so successful, and they get rid of a lot of these kind of problems with stability and grip and things like that, movement. So we check the frenums, tuberosity, do have combination syndrome, things like that. Of course, they're going to be a problem. Anything that's soft and mobile in the mouth, if you then apply pressure when you're taking that impression, you will distort that. There's no two ways about that. So what you want to do is you want to try and distort this tissue as little as possible, because you'll get a more accurate fitting denture, and it'll work much more in harmony with the mouth than something which is overextended and pushing into tissue. Check the hamular notch. Is that sort of quite high? Because that can cause a problem as well. And check, call them the paratubular pockets. And these are the areas which, if you put your finger right up, right to the side of your tuberosity and move your jaw left and right, you'll feel like the coronary process jam your finger. And if you don't take that into consideration when you're making your dentures and you incorporate the shape and the space available up here in your impression, then when, for example, a man's shaving, when he does that, it'll move, there won't be enough space here, and it can cause real soreness or dislodge the denture. The denture may fit really nicely, however, it'll be dislodged. And there's two different things. There's a denture that doesn't fit very well and drops, and there's a denture that is obstructing something and drops. And they're two different things, and you have to bear that in mind. So we really need to take notice of this area here. So when we're doing our impressions, we get the patient to move the jaw left and right, and we record the space. So that's on the upper. Obviously, there's many things I could go into here, but we've only got roughly about an hour and a little bit. So I'm just going to go through the basic sort of examination. Same with the lower. We check our ridge. Is it bony, bumpy? Is it flat? Is it flabby? Because this will directly affect how the laboratory will make your tray. It'll give more space and more relief, many different things. Frenums for the same reason. Retromolar pads. These become very important when you learn the Dr. Abe technique, because I didn't realize there was so much goes on with a retromolar pad, how much distortion there is when the patient opens and closes, are they mobile, are they firm, and they all have a direct effect on how this denture will perform. So we need to just take a note as to the condition. Are they present, are they visible, are they just pretty much non-existent? Buccal shelf, do we have much bone there, or is it completely resorbed? Is the tissue all mobile over it? Because all of this will move a denture if you don't take into consideration what happens. And the mylohyoid line, this is very important as well. We're always taught not to go over the mylohyoid line with a denture. However, there is a way when you do the BPS advanced, which is essentially Dr. Abe's technique, there is a way using his technique and his impressions that you can go over this You've got to combine it with certain movements and a certain tray design, but you can go over that by around 2 to 3 millimeters, and it makes a huge difference. You can actually create a seal there. But we need to basically make sure that we can see this, because this will, on the BPS system, be our final line for the design of the denture. Okay, and sometimes on real atrophic bridges, that just, you can't see it, it's just all tissue, and that can cause a problem. So, first appointment in the clinic. Excuse me. This is what we do: primary impressions using Accudent and the centric tray. Excuse me, So, the Accudent tray system has been around for an awful long time. It's an excellent system. They stopped making it in the case now, so you just buy the individual trays from Metrodent. I think they sell them individually, and they're all different sizes, different depths, different shapes, and they're autoclavable. And once you've got this system, yeah, you've got it for life. I mean, they last for ages. I've had a set, I think, for 15 years. So I've never had to buy any trays for 15 years using this system. And this is how we select them. You can use your compass, you can use the patient's old dentures, just basically measure the tuberosity width and the retromolar pad width. You can position the dentures in them. Obviously, this is not the best way, because you've then, if it's the wrong size, you've got to autoclave 2 trays for nothing. So something like a compass would be good, and you just match it up as near as possible, and then we use it in conjunction with this alginate. And Accugel was always the material that was used with the BPS system, but Accugel was actually discontinued a couple of years ago. So the replacement is pretty much the same material as the neocolloid and the tropic algin from Zermatt. And you have a syringe. I'm a big fan of the syringes because it enables you to position the material where you need it, and then the tray essentially acts as a pickup. So that's the beauty of it. A lot of people think, oh, you're syringing and then you're piling an impression in, it make the patient gag a lot more. It actually has the opposite effect, because when you're positioning it and then just picking that syringe material up, it's a lot less material in that patient's mouth. The patient doesn't feel like you're just pushing it all the way home and it's going to come off the back, and then the panic. So it's a very, very good way of doing an impression. So first off, we mix our syringe material, and then we mix our tray material. Now the syringe material will go off slower. So you mix syringe material first, then the tray. And you position it, because you position this anteriorly first and then rotate it posteriorly. And then as soon as you see the material come off the posterior edge of the tray, you stop pushing. It's thixotropic, so it won't run off the back of the tray itself. So you load it more to the anterior than the posterior on the upper tray, in that kind of shape. And the beauty of this is you can put it under the tap and rinse it, and it'll kind of give you a real beautiful, smooth, glossy surface. You get a real nice impression from it. We then pop that in the patient's mouth, go start at the tuberosity and come round to the midline, and then do the same on the other side. Put a little bit in the palate, and then position your tray anteriorly first, and then rotate it posteriorly. As soon as you see the material come off the back of the tray, stop pushing. You don't need to do any more. And then you've essentially captured everything in an overextended impression. Now, this is just for the trays. You wouldn't do this kind of technique if you were doing functionals. This is purely to get an overextended impression, so we can see all the anatomical landmarks. Well, a good way of finding the post-arm, this is one of the best ways that I've found, which really improved the retention of my upper dentures dramatically, because I always used to just mark them on the model, but really the lab doesn't have a lot of information in order to do that, so it's kind of guesswork. They'll draw it on, but what you're actually trying to capture is that junction between the hard and soft palate, and only you as the clinician can define where that is. The lab can't offer a hard model. So it's really beneficial if you use a couple of these techniques. You can get the patient to below, if you nip their nose, you'll see the soft palate come down. You can use a burnisher. You can get the patient to see art. What you'll see is the soft palate move. And then you can take an intraoral marker. You can buy these from places like Bausch, B-A-U-S-C-H, it's a German company. And they're just disposable intraoral markers. But the beauty of this is you can identify that junction really accurately, and I promise you this will make a big difference to the retention of your upper dentures, for sure. All you have to do then, once you've done the RIMP, is mark it, put the impression back in, and then the ink will come off onto the impression and then just highlight it. And then what you'll get is you'll get a custom tray made by the laboratory, which will be extended perfectly to that line. So you'll be getting the best extension and the most accurate extension for your upper dentures, particularly when you're doing your post-dam. So that's a great way to do it. With the lower impressions, you use exactly the same technique, syringe and tray material, except with the lower, you will position it more to the posterior first, because you rotate it the opposite way. So pop it in and then shape it so it's more weighted to the posterior than the anterior. Again, with the syringe, start at the retromolar pad, come round, all the way around. Make sure you fill this in. This is like a real thin alginate for high detail, so it's real nice material. And then we position the tray in situ. You have little finger stops so you can apply even pressure, do a couple of movements, and then you'll have some real nice impressions. And this is just your starting point. This is not functional impressions or anything, but you've got all of the information that you would possibly need. And then we use our centric tray. Now the centric tray is Ivoclar's technique for giving you a preliminary jaw relationship. It's not the bite as such, it's just a jaw relationship and a primary OVD, occlusal vertical dimension. And it's very, very accurate and very predictable and extremely useful for NHS dentistry, for private dentistry, for partials, because it helps the lab. What it enables the lab to do is articulate those models. And once they've made your bite blocks, they can then put the models onto the articulated models and adjust them so they come together in approximately the right position. So when you get them back from the lab, instead of the usual where you put the blocks in and then you've got to carve the blocks to try and get them to come together, you get these back when they've been mounted with a centric tray, and they'll just come together. And it makes your job so much easier when you're doing jaw registrations. So for wax blocks, you can use them, but for we use them primarily on here for setting up our custom trays and Gothic arch tracer. And it works on this principle. So it works on the principle, simply put, there's a lot of words on here, but simply put, if you were to hum now with your natural teeth and you put a dot on your chin and a dot on your nose, you would have a freeway space, and that varies, but say for average it's about 3 millimeters. And then if you got one of your dental colleagues to take all of your teeth out and hummed again, the dots would be in the same position. So if you were dentate, for example, I'm dentate, if I put a dot there and a dot there and I hummed and I measured it, and for example it was 70, and then Paul took all of my teeth out and I hummed and I measured those dots, the distance, it would still be around about 70. It's pretty much 70. We've tried it on a few immediate cases and it's pretty much bang on, within half a mil at the most. So what this enables you to do when you have a patient who's completely edentulous is if you can get them and put a dot and a dot and get them to hum, measure it. I found humming's the most accurate way of doing it. Measure it. That will give you an approximate relaxed OVD. And if you then take 3 millimeters off that, which would be your freeway space, you can get an approximate closed teeth touching OVD height. That makes sense? And with a bit of practice, this is really, really predictable. So that's what I do. Dot, dot, measure, say for example, 70 millimeters, and then I get the patient hum, 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 measure it, 70 millimeters, yeah, great. So I know if I take 3 millimeters off that, I'm going to be roughly 67, which would give me my closed mouth OVD. So that will give me where I need to close back down to. So I use a centric trace, just like a boomerang with 3 little prongs on. Position that in place with alginate. You can use putty, it doesn't really matter. The softer material may be the better, because the more firm the material, the more they'll feel they've got a bite and they can protrude. There is a little tongue stop inside, which if you ask the patient to put the tongue on, it helps keep the jaw in position and stops them protruding. So pop that in situ, and I just get the patient to close down to either the 70, or if I want to get them to close down into a closed mouth OVD measurement, I would get them to close down to 67. Hopefully that makes sense. It's pretty straightforward, but if you haven't seen it before, I know sometimes it's a little bit tricky. And then you'll have this at the end of it. You'll have either an alginate centric tray or a putty centric tray. It doesn't really matter. So that will go back to the laboratory, either one of those centric trays, doesn't matter, with the primary impressions. And then the lab will create custom trays, and they will incorporate into that the nathometer. Nathometer is the Gothic arch tracer. We'd start off, we'd mount the models, we'd cast the models and mount them using the centric tray, and we'd mount it onto the articulator. Do any blocking out that we need to. This is why it's important. We need to know if there's a flabby ridge, combination syndrome, if there's whatever sort of problems going on in there, because we'll then make our trays accordingly in the laboratory. So put our bases down, ready to incorporate the nathometer. You can use light cure base, it's not a problem. And we'll tend to position, when those are mounted, we'll tend to position the nathometer at halfway. So essentially like bite blocks. You normally get 2 wax bite blocks, and they'd be roughly half the height. With this, it's a bit more accurate because you've got the centric tray to guide you. So you mount those models, you can see roughly where the bite is, you know it's roughly at the right OVD. So we'll take that at a halfway spot and use a level occlusal plane halfway between the anterior sulcus and in line with the retromolar pads, about halfway down from the top of the retromolar pads. And then that is where we'd mount our nathometer. Okay, so this would be your essentially custom trays incorporating the Gothic arch tracer. That's what you would receive back. So this would go back to the dental surgery, and when you position those in the mouth, that's what they would come together like, because you've used the centric tray. Whereas normally, if that was bite blocks, or if you hadn't used the centric tray, they just wouldn't come together like that. You'd be carving, you'd be modifying all of this. So second appointment in the clinic, functional impressions and Gothic arch tracing. For some reason, my dog's gone crazy. Functional impressions and Gothic arch tracing. So I use virtual. I've used virtual for many, many years. It's a real nice material. I'm a big fan of it. It comes in all different viscosities. You have heavy bodied, light bodied, medium bodied, extra light, putty. You have the adhesive, and it's really predictable. Most of my friends, most of the dentists that I know who do this technique swear by this. It's a great material. I really like it. We start off, we'll use our heavy bodied. If it was flabby ridge, maybe I would use medium bodied, just so it doesn't distort things as much. Put our tray adhesive on, very important. Use silicone tray adhesive, not alginate. Still people do that, and then the silicone just falls off. So make sure you've got the correct tray adhesive, and go around the periphery and seat that. We get the patient to do certain movements, suck on their finger and bring the top lip down, move the mandible left and right. That'll capture this pocket up here. And we pop the lower tray in so they've got something to bite against. So then your fingers are out of the way completely, so you can get a true functional impression now. So that patient will now close together, and because the trays are hard, they can bite as hard as they like, it doesn't make any difference. And then you get them to do some big smile, blow a kiss, getting this functional movement going on. And what this will do is it'll record the movements of the tissue and the shapes of the tissue during normal everyday function, okay? And that's what we're after capturing. It's very important, so you have this functional impression to work in harmony with those tissues and not against it. Very, very important. We then take off our excess, any high spots, put in our light bodied, obviously put some trade adhesive on, put the light bodied, and this will capture the fine detail of that impression. And we basically just repeat those movements. And put the lower in, and once we've got those, I'm distracted because the postman's just putting the things on the window, sorry. Put the upper in and put the lower in, and then we can repeat the movements, get the functional impressions. Big smile, blow a kiss, big smile, blow a kiss. And then you'll have a real nice functional impression. And you can see all of the detail on here. You've got the frenums, you've got all of the shapes. Now, these are not generic denture shapes. You know how a generic denture shape kind of does this? With functional impressions, you don't get that. You get whatever shape that patient's mouth is. So they all look different. They all have some similarities, but they all look different because it's a fully customized functional impression for that individual patient. So this is what I really like about them. If you have any sort of voids or little air blows, you can fill it in with extra light. Me personally, I wouldn't bother. I would leave it and let the lab modify the model. I think you'll get a more accurate impression, because quite often if you try and fill this in, it'll flow over and you'll get a little join line. And to be honest, in the lab, we can sort that out really, really easily. But it's up to you. Just got to be a bit careful with it. And now the lower, we do our heavy bodied all the way around. Again, sometimes you could use a medium bodied, which we call a monophase, but it just depends on patient's tissue, the elasticity in it. Sometimes if you have like a patient who's 90 and smoked 60 cigarettes for the last 50 years, the cheeks are just like paper thin. So you don't want anything heavy, because it'll just distort, and it's really difficult for the patient to actually function and get those functional movements recorded. So you want to just wind that thickness of that impression material back a little bit. So that's why sometimes I would use a medium bodied, but it's just the same process, it's just changing materials. So adhesive, and then we go around the periphery, pop that in situ, get the patient to stick the tongue out, left, right, again recording those muscle movements, pop the upper in, and then they can bite together. And they can put as much force on as they want. Big smile, blow kiss, big smile. And you can just repeat these movements. Get them to stick the tongue back out, just hold it in situ. And you'll get a real nice impression, and you'll get a real accurate shape of what that patient's tissues are doing when they're doing normal movements. Take the excess off, just go around on the crest of the ridge. That's what I tend to do. And then put the light bodied on, repeat the movements, exactly the same. And you'll have some really nice impressions, which will be fully functional, correct if you need to. Again, wouldn't really bother. And that's what you'll end up with, is you'll have fully functional impressions. The templates will be perfect against each other. And these little white shims on the mathometer are removable. So what you remove those for is when you place your tracer in. Now, one of the most common things I would say is getting the OVD wrong. I have a video. I've got a little link at the end of this presentation, which will enable you to follow it, and you can go have a look on the Iberclaw website. And there's a lecture I did. It's a couple hours long, but I put it together, and it basically addresses the most common problems I've found with dentures. So wrong bites, wrong OVD, tooth position, and how to identify these problems, how to avoid these problems. It's basically 2 hours of tips and tricks out of my head of stuff I've learned purely relating to dentures. So it's pretty useful, I've been told. But OVDs is seemingly one of the most difficult to get right. And if you get this wrong, you can have it where it's too small. I mean, that'll aesthetically and stuff not be great, but you can't have it too tall because it's just redundant. You can't use that denture if that teeth are hitting each other when the patient's speaking or trying to chew. You know, you need that freeway space. So at this point here is when I would be assessing my freeway space, because that'll give me a real good idea if my OVD is correct or not. And if it's not, at this point, I need to identify by how much it's out and then correct it. I can't leave it where it's wrong because the trying will be wrong, the fit will be wrong, and I'll be remaking these dentures. So this is a real important part. And the easiest way I've found to do it, there is a way to do it. You'll get people tell you there isn't a way to do it. There is definitely a way to do it. It's by this. You can use this on blocks. You can use this with the Gothic arch traces. Doesn't matter. But when you speak, your teeth don't touch to the natural teeth. And if you look around about the 3-4 region, because if you have a class 2 or sometimes the teeth, when the patient speaks, you can't really see, but you can generally see around about the 3-4 region when they speak. Have a look at the space. And you want a space between the upper and lower either blocks or shims here of around about 2.5, 3 mil, something along the lines of that. I wouldn't go much more than that. What you don't want when the patient's talking is for those to hit, because that's indicating your OVD is completely wrong. And what you don't want is a space of about 6 or 7 mil, because that again means it's too small. So I get the patient to speak. And it's a really, really accurate way. So have our impressions. I'll show you this. We'll have our impressions, which fit beautifully, all good. Check. You can get them to bite on a cotton roll. You can get them to bite on anything, a bit of silicone. We use silicone putty. Get a hold of the impression, check it. And this is the most important one I find, because this OVD in the bottom right-hand corner, get them to speak. And when the patient speaks, see these white shims, how there's like a space when they're speaking. Now, if they're touching when they're speaking, S is the closest. If they're touching, your dentures are too high, your OVD is too high. If there's a space like that, that's perfect for me. I want a space of around about 2.5, 3 millimeters. Because what that'll mean is, if I maintain that same height when I do my trying and my fit, that the teeth won't touch together, the OVD will be correct, I'll have the correct freeway space, and it'll be successful when I fit the dentures and the patient's trying to eat. Now, these little white shims do come out, so if that's hitting, you can take a shim out, and those shims are 2 millimeters tall, so you can instantly reduce that OVD by 2 mil and check it again. And if it's still a little close, you can take the other shim off. That'll basically give you another 4 mil of space. And if it's about right then you know the OVD of these trays with those shims in is around about 3 millimeters too tall. So the lab can just reduce that OVD really easily. But using that little technique there it's pretty much foolproof. You'll not have another wrong OVD. And it seems to be one of the most common problems people have issues with. So we have our functional impressions. Everything's revolving around the campus plane, the articulators, the face bows, setup templates, everything. And we have our, it's a bit like a fox's plane, but it's from Marita. It's a very thin 1 millimeter fox's plane, but it's kinked, so it kind of comes up higher. It's a really nice bit of kit. Obviously autoclave it, it's metal, and it's got a little mid lining as well, which you can line up, and it enables you to get a real accurate recording of how close the occlusal plane is to the campus plane. So the occlusal plane of your blocks and the campus plane of the patient, you can see by putting this in between the two shims how close that is. And then you can make adjustments. It's real easy to do. All you have to do is see the patient's face there. You've got a few millimeters from where the campus plane will pass through the ear. So If that's maybe 3 millimeters, then you would just say to the lab, raise patient's right-hand side occlusal plane, and we use these little horizontal guides to do it, raise it by 3 millimeters. Left-hand side's fine, right-hand side is 3 millimeters too low. And what we can do in the laboratory is then just adjust it. And you'll get an occlusal plane, which when you get the try-in back, which will be spot on with a campus plane. So again, you're taking out this guesswork. So you know how when you do a try-in and you have like a cant on it, and you think, oh, well, this gets rid of that. It's a brilliant bit of kit. So in the lab, I'm not going to go through this too much, but we use, it's not guesswork, we use proper templates using model analysis to articulate the models correctly in the articulator. I use the Stratos articulator. If you want to use a face bow, you can by all means use a face bow to do the same. We have all the transfer jigs which will go straight onto the articulator, no problem whatsoever. I never used to be a big fan of the face bow, and then the more I learned about how to make dentures more functional and more stable, and the importance of the occlusion in full folds, I learned from Dr. Abe and Kenji Iwaki in Japan, who are a couple of my mentors, how to use the face bow and the condyle angles and things like that, and dial all of that into the fully adjustable articulator, and then do fully balanced occlusion on the full folds. And that changed my dentures just dramatically. So now I'm a huge fan of the face bow, and I use it for all of my work because of the ability to then grind things in and the excursions, get the wear facets correct. It's a fantastic way of doing it. Not many people use it on complete dentures to its full potential, shall we say, but it's a great way of doing it. Gothic arch tracing, as I say, these little white shims just clip out. When you clip them out, obviously the 2 millimeters, so if you're taking both of them out, essentially you're taking it down by 4 millimeters. But when you pop the shims back in, these little metal shims with the pin and the plate on, the little traces, there is a screw which has a chamfered tip. And if you wind the screw down, see in the middle there where the chamfered tip is, it's just like popping through. It's a little pin. So if you have that level, then it's 4 millimeters that is above. So you're actually not changing the OBD at all. You can change it if you want because it's a screw, so you can make it higher or lower. But if you take those 2 shims out and pop the plate in there on the bottom left-hand corner, you can see the little pin popping through. The distance from where it's level with the plate to the tip of that pin is 4 millimeters. So nothing's changed. Okay. Pop it back in, and that's what you'll see. So there's nothing else in contact. No impression material should be in contact or anything. Just the pin and the plate. And then you get the patient to slide. And the beauty of this is you're not guiding the patient. You're not doing anything. You're recording what that patient's doing, which is the correct way of doing it. So get the patient to slide left, right, forwards, and it'll scratch into the wax pencil that you've put on. You just heat up the plate, put a bit of wax pencil on. And what it'll give you is a tracing. And this is from Professor Gerber, who's a bit of a godfather of removable dentures. And it's a point where all of those movements start from. So the way the mandible does this, it's kind of got to come back. If you think of an engine, it's sort of top dead center on the condyle. It's got to come back here before it goes left to right to forwards. And the point there is the position where all of these movements start. So it's got to be centric. It can't be anything else other than centric. Centric couldn't be halfway down either of those lines or anything. It has to be where all of those points, all of those movements start, congregate together. So we put our little verification plate over the top. It's got a hole in it, tighten it up, and then pop that back in the patient's mouth. And then what will happen is that pin, when they tap, that pin will go straight in that hole, over and over again, and you have basically confirmed centric. It can't be wrong. I've used this for years on so many patients. It's just never wrong. Unless you don't interpret the information correctly, or something moves, do it properly, there's your wrong bite, gone forever, I promise you. And then we'll just bond that together using some bite registration material, mark our midlines, and you'll have functional impressions, correct OVD, jaw registration bang on. So at the second appointment, you're at this stage, and this is a fantastic position to be in because you've got everything right. So from this point on, it's pretty difficult to sort of then have problems. Everything else is just get the tooth position right and the aesthetics right. Make sure you keep all of this detail by processing them correctly, and you've got great dentures. It's really simple, it's really straightforward. A few different ways you can pick the teeth. We all know the shade guides, form selectors, live and mold guides. There's a bunch of different things. But the digital sort of world is fast approaching, and it's infiltrating everything now. And we've been doing these sort of things for quite a few years with digital dentures. And you've got these sort of things now. It's an app. Ivoclar brought an app. There's lots of different smile design apps. But you can basically have the patient look into the screen, and it'll allow you to then modify the teeth in real time with the patient looking in it. So it's augmented reality. So you can use sliders, and you'll go from patient's natural teeth to the proposed new smile, and you have all of the denture molds from the teeth in here as well. So for a patient to be able to see a soft mold, or if it's a man, quite a sharp mold, it can save you a lot of problems on try-ins and things like that. Because you can tell the laboratory, I want S72 mold, and I want it in shade A1 because you can change the color on this and everything. And it's changing how we do our appointments, really. So you can download this for free. It's a very, very cool little app. I'd recommend you have a little bit of play with it, really. I have a smile. So then that would go back to the laboratory with any information that you have, molds and all this kind of thing. The lab would then use their techniques. So we'd set the teeth up to an average value, because there's a lot of studies being done by Ivoclar when we put this BPS system together, and it was based on average value. So with regards to tooth position and things like that, there's certain rules you can't stray from, but for the likes of anterior tooth position and size, you can use the model analysis and get some real good results. So for example, things like this, it's always an interesting one. Average value doesn't apply to everybody, but if you go halfway from the papilla, the average position for the labial aspect of the upper incisors is 7 millimeters. So Ivoclar make their teeth 7 millimeters, more or less anyway. So if you position the palatal aspect of the tooth when the technician's setting up halfway over the papilla, it automatically puts the labial aspect 7 millimeters further forward, which is the average value and the average position for upper incisors on regular patients. So there's a bunch of different things we can do in the lab which help put these teeth in a more accurate way, in an accurate position for your try-in. Model analysis is a huge one. This is why we need good primaries. We need to have all that information, and functional impressions give us everything. We get the pound line from it, crest of the ridge. All of these things here are super important to position these teeth correctly for maximum stability. And if we don't have this information, then these teeth can be set incorrectly, where they're too far lingual or too far off the ridge, and then you'll get midline fractures or tipping or speech problems, a whole bunch of things. So we use all of that information gathered from these beautiful functional impressions, and then we do our model analysis, in order to set the teeth up correctly. Take your pick on the articulator. The Stratos 100, 200, 300, they're all essentially the same articulator, except as you go up, they have more adjustability in them. So the 100 is a great workhorse, but if you want to do the higher end, sort of the face bow and record the condyle angles, custom angles, you would need the 300 because that's essentially fully adjustable. So I use the 300. I've got a few of those. They're a great articulator, but there's something, you know, for everyone along the way. And they're all they're designed. There's a bunch of design features in them, but they're all designed around the bond roll triangle. So your incisal tip of the lower 1 to your condyle angles, average 108 millimeters. So we use the templates to position the model and the tooth setting templates to position the teeth. So by the time we're finished setting up everything, the lower 1 will be 108 mil in the bond roll triangle. And it's the most accurate way of setting teeth up in a predictable fashion to be as close as what it can be in the skull. It's a very clever way of doing them. These are just some of the templates and principles that we use. We use this horizontal guide for mounting the models in the articulator quite a lot. It's just no guesswork in it. It removes so many of the problems when you do it like this. And again, face bow, if you want to use the face bow, you can either put the face bow directly on the articulator, or there's a jig which you can use to mount the model onto the articulator. 2 ways. So you can either keep the face bow in the surgery, or you can send it. Doesn't really matter. The lab will have both options. Nice universal joint to attach it. Setting up the teeth, certain rules for this as well. You don't just set them anywhere. It's all to do with phonetics and giving the tissue enough support. It's one of the biggest things that is a giveaway for dentures, is the teeth are set too far in. And it's a habit thing, really. When the labs set them up, they tend to set the anteriors too far in. And when you give the dentures to the patient, all of this just disappears. It just goes. Whereas if you follow some of the rules and position the teeth back as closely as what they would have been naturally, and this is what this whole system does, you'll find, particularly on ladies for things like lipstick and stuff, suddenly the top lip appears again. They've got a top lip. The top lip never goes anywhere. You know, when you get dentures, it just disappears underneath here because the tissue support isn't there. But if you put that tissue support back, suddenly this top lip appears and they can put lipstick on, just things like that. And these are the steps we use to follow them, the process. We set our upper 3 to 3, follow our model analysis, lower canines, and all of these are set half the distance from the sulcus, plus 2 millimeters or plus 4 if it's a class 2. There's all different ways to set these teeth up depending on what relationship the jaw is, you know, what kind of tissue we're setting it on. We have little techniques how we can overcome a lot of the problems and make it more stable. And then we use our set of templates for the posteriors, and to get the correct curve of Wilson and curve of Spear. We make sure the teeth are actually in contact with the templates, because the teeth were designed to work like this. You know, this is how the designers of the teeth incorporated the cusp angles and stuff to work with this curve of Wilson and curve of Spear. So it only makes sense, if you're going to do it properly, to use the correct templates, and it's just by far the best way of doing it. You can do lingualized occlusion as well. There's templates for that. Lingualized, I'm a big fan of that. I really like it. It's for me, it's a real predictable and easy way to get fully balanced occlusion. Or you can use normal type setups. The teeth will go either way. You can get either ones. They both work great, but I'm more of a fan of the lingualized. And by then, you're at a point where really your teeth and everything and your extension and your functional impressions are all working really nicely with the patient's anatomy, but you need to then carve your waxwork. So again, you're following this example here by Dr. Strack. So it's not overbuilt, it's not pushing into areas where it shouldn't be. So it's going to work in harmony with that patient. So we carve it. There's a certain way we carve it to give the buccal tissue space to move. And we carve the anterior to give the tissue support. And you'll get a denture that looks completely different to what a normal denture looks like in terms of support for the patient, filling the face out, but it's stable. It's been set up, accurately and within parameters that ensure the stability of the final dentures. And obviously the teeth come together perfectly. We do everything correctly. So the teeth, the try-in is ready to go. Goes back. You're not going to have a wrong bite. The OVD is not going to be wrong. You might have a little aesthetic change or tweak or whatever, but 80%, 90% of this is going to be guaranteed right. You can't say that with regular approaches. It's just, I've done it for years and it's just not as predictable. This is predictable. I know the bite's going to be right. I can listen to the patient speak. I can check the OVD. I can see how much space there is when they're speaking. Because whatever this is going to give me now, I'm going to process it and I'll get exactly the same in the final denture. So if everything's good here, the fit, the OVD, the aesthetics, the space when the patient's talking, stability, as long as I use a real high-end way of processing those dentures, then my dentures will be exactly the same as it's going to come to fitting. That's what you want. Processing. For me, either cap or either base. Those are the two most accurate ways. You've got 0.6% shrinkage, volumetric shrinkage. It's the lowest out of anything, other than milling. Milling's zero, well, just above zero. But regular processing of dentures can change them quite a bit. You can have like volumetric shrinkage of 3-4%. And if you think about that, that's quite a lot. If you've gone to this degree of care and getting the impressions and bite and everything perfect, you want that denture to be as accurate as you can possibly be and mimic that final silicone impression as closely as possible. So I don't want that denture to change by 4% or 5% in the processing. I want it to change by nothing. I want it to be exactly the same. But the nearest I can get is 0.6, 0.7% by using these. So what I use, I've used them for long before I started working with Ivoclar. 10 plus years I've used this. And it's an injection system. So basically what it does is it compensates for the shrinkage. So monomer-polymer mixed and then cured, it has shrinkage. This applies the heat from the top down. So the bottom of the flask is always soft. And as it's processing and you're having the shrinkage, it's pumping in new acrylic. So it's compensating for that shrinkage. So this is why you get such low levels of volumetric shrinkage on your final dentures. Works the same for the Ivocap. The Ivocap's the original, the Ivobase is the new machine. Both work same kind of way, and you get the same kind of results. Same materials as well. You can use the Ivocap in the Ivobase. And this is what you have. You can put this back onto the articulator, which I always do, and the OVD will be exactly the same. If you do that on normal processing, it's very rarely perfect. Very rarely. You'll always have a bit of an anterior open bite. And if that isn't then ground back in, by putting them back on the articulators and then being ground back in and checked, then when you go to fit it, you'll have a discrepancy in the occlusion. Might not be much, but generally it's there. So by putting the jobs back on the artic and checking them, and just making any adjustments, it'll be the same as what the try-in was, which is exactly what you want. So this is the workflow. So we have BPS and conventional. So 4 or 5 appointments. As I said at the beginning, it's a bit more time involved in the BPS, but it is high-end private. And you do reap the benefits post-fitting with regards to the review problems, adjustments, soreness, wrong bites, blah, blah, blah. And again, I cover this in that other lecture I did, which if you're interested in removables and you have problems with removables and you want to get better at removables, I'd highly recommend you go and watch it. It's called Avoiding Complete Denture Disasters, and it gives you loads of tips. I put pretty much everything I can think of in that. lecture. So that goes back to the surgery. Centric position, you can check, shouldn't be any different. Check the stability, protrude, get the patient to protrude. And because these teeth have been designed and set up with the correct templates and then ground in and checked, this is what you see. You don't see this with normal dentures. If you get the patient to slide left and right over each other, you'll see the top denture usually just wiggle about all over the place. And it's because they haven't been set up as accurately as they could be using the proper templates and then being ground in. So you end up with dentures that fit, they look nice, super functional, and this is the stability of my dentures. This is a full, there's no glue, no implants, nothing. That just isn't moving anywhere. The patient can bite, chew, talk, they look lovely. You know, this is what you're after. This is a system to do this. This is not guesswork. So it's kind of a fast track to become really good with fulls and partials. You can apply it. Well, this is what you'll end up with. Real nice aesthetics, real nice tooth support. It's suitable for all approaches, implants, combinations, hybrids, partials. You can modify it to do Gothic arch tracing on the partials. You know, it's pretty much nothing you can't do with this system. You know, it'll cover everything. These are just, I put these in just to show you some pictures. These are some dentures that I've made over the years, all using the same principle, all using BPS. I put a bit of lipstick on them and characterize them with my composite system, the Nexco composite system from Ivoclar. But that's just lipstick. That's just, you know, making it look like the patient wants it to look. But the main thing is the functional impressions, the jaw relationship, how the occlusion is, how the teeth work over each other, the stability. That's by far your most important aspects. The aesthetics and the pretty bits is, you know, it's on the periphery really. You've got to get the fundamentals right, and this gives you the fundamentals, you know. If you are interested in any courses that we do, I think we're going to be starting them up in September again. That's what we're aiming to do anyway. You can take a screenshot of that. These are the Ivoclar courses, the core courses that we do at the ICD in Leicester. That's the girl you need to speak to or send an email to. And we'll be doing BPS, technical, the clinical ones. We'll have to see how it goes because we do a clinical demonstration. We'll have to see how that goes with regards to COVID and getting a patient in and all that. So they might not start running until next year. We do the Dr. Arbe ones, we do the IVA-based ones, we do the digital denture ones, which will be clinical and technical. Again, COVID dependent for getting a patient in. And if you do want to have a look at any of the other webinars that I've done on the denture disasters and things like that, if you go to that academy on the bottom, it'll just have a look on the webinars on demand. You'll see it on there and have a look, but you'll get a load of tips and helpful stuff out of that, hopefully. So just say thank you very much for your attention. I know it's through the day, so it's, you know, most people will be trying to get back to work, so I appreciate you taking time out of your day to watch this. And I don't know if there's any questions or not. Maybe Louise can help us out on this. If there is, yes, there is. I shall stop sharing my screen. And right, questions. Right. Okay. Right, so what's the name of the app? So the name of the app was IvaSmile. And you can just have a look for that on the App Store. That's no problem. You can go on there and it's free to download the basic version of that. Chat-wise, let's just close that. Oh, the sound's gone off. Can't hear anything now. Did that last very long, the sound? Problem?
No, I can hear the sound.
All right, okay. A couple of people saying they couldn't hear the sound. Does BPS work well with resorbed ridges? Any modifications need to be done? Yeah, it does. It works very well with resorbed ridges because you're using the functional impressions. Modifications would be done with regard to maybe the tooth position. You've just got to kind of make everything work over each other, the teeth work over each other as smoothly as possible and not, I call them trips. So if you have, for example, the cusps and they really interlock and don't slide over each other nicely, as in they've been ground in properly, then what happens is when the patient slides the teeth over each other, it kind of trips it over the cusps and it can cause it to dislodge. But with regards to impression wise, it's the same process. There's no real difference in the process. If you're doing the Dr. Arbia one, then there's a difference. But for BPS, if it's a resorbed ridge, the only things you would really maybe look at is if the nerve was shown on the mandible, you would give a bit of relief. You would check that on your examination. But no, regular approach, same approach, regardless. The only real thing you would modify is for the flabby ridges and things like that. You would just give more space, or you would give a window at the front. So it's an open tray technique, which you can do with the traces as well. It's not a problem. But yeah, that's fine. So yeah, I think that's it. There's no more questions, is there? Or have I not? Oh, hang on. Okay. I understand that there is no wax bite to take the bite, but I use it to decide how much labeling I need to place the denture and support the lip. I also decide how much teeth to show when the patient's smiling. Yeah, so it's not a problem because it's very easy. All you do with that, if you want to use wax to modify it in the way that you would do a block, you can add the wax onto the custom tray exactly the same as you would do with a block. It's no different. All you've got with your hard custom trays is essentially a hard bite block. So you can add wax to it. Quite often people will put impression material on the front of it. So like the jaw registration material, bite material really. So once they've done everything and their upper and lower functionals, they'll put some bite material over the front and then mold it and then let that set, and then the lab can use the shape of either the bite reg on the labial aspect or added wax on the labial aspect. So the same as what you would do in a bite block, you can just do on the tray and use that. So it doesn't stop you doing anything at all with regards to what you can do with a bite block regularly. It's just exactly the same. And again, for your tooth, for your lip, there are, like I say, with the tooth setting protocols in the laboratory, there is a procedure to follow. But if you want to add the wax, 2 millimeters on, you can do it and just say use level of wax for tooth setting, and then the lab will do it exactly the same. No problem there whatsoever. Elaborate on the lab procedures during the tray fabrication. That's, I can, let me just work out how I would do that, because I'll have to go back onto the presentation and show you, but I can do that. Is there anything specific, because it's quite a long-winded thing, it's quite a broad window you've given me there to do. Is there anything specific you want to actually know? Technique to locate, what is the technique to locate BPS point? BPS point, maybe. I think maybe you'll be talking the BTC point, maybe, not BPS point. You'll be probably on about the Dr. Arbia BTC point, is that right? If that is the case, then that automatically shows itself when you do your functional impressions, where the cheek and the tongue meet each other over the retromolar pad. It'll kind of form like a small fin over the top of the pad, and that's your BTC point, buccal tongue contact. So you don't actually do anything, the patient forms that. So that will kind of like just be formed over the pad in like a fin where the tongue and the cheek meet when you do your functional impressions. I hope that's what you mean. Okay, both the trays are placed together during functional border. Because, okay, so Asmi has asked why both trays are placed during functional impressions, because that's the only way you can do it. Because if you think about what we're actually doing here, if we want a truly functional impression, the only way you can do that is for your fingers to be out of there. If you've got your fingers in a conventional way with a big fat special tray and loads of alginate, and you're a patient like that, you're not capturing what that patient's functional movements are at all. You're getting an overextended impression. So in order to capture a true functional impression, the patient has to be able to do what you do now with your teeth. So they have to be able to bite it there, stop, and then move everything around. If they only had one impression tray in, as soon as they did that, it would fall out and they've got nothing to bite against to keep everything in place. So you need both of the tray impressions in place, the trays, sorry, when you're doing the impressions, so the patient can do all of their movements in a closed mouth position, which keeps everything still and apart from the tissues, and then you'll have your proper functional impressions. So that's why you have to have both of them in. How to block out severe undercuts and still not lose the seal, especially in the anterior mandible. Right, so Mehdi, I think you're talking more about the RBA stuff. So that, I'll tell you what I'll do, because this is a different technique you're talking about and what we're talking about. I'll answer your questions on a messenger, because these are not really BPS questions. These are more Dr. Arbia ones, if that's all right. How flexible is the denture? Well, the denture is regular high impact material. It's not a flexible denture. It's a regular, normal high impact material, hard acrylic, PMMA. For conventional dentures, the custom trays are made 2 mil short of the sulcus. Similarly, any specifications? Yeah. So when you're doing the tray, all right, okay, got you. Yeah. So when you're doing the upper trays, you go around the same peripheries. You're around about 2. Depending on if there's real big frenums or anything, you might want to go a little bit more and use a more of a medium-bodied material to capture those a little bit better. But yeah, 2 to 3 millimeters is what I remain short. I always come back quite a way, because I'd much rather have the tray a little bit shorter by 0.5 mil or 1 mil, and then get all of that functional impression material molded correctly without the tray being in the way. So yeah, what you're seeing there, 2 millimeters, 2-3 millimeters, perfect. That's what I have on mine. Any special technique for flabby ridge? It depends if it's an upper or a lower, but if it's an upper, there are different impression techniques you can use. The simplest one, I mean, if you think about what a flabby ridge is, it's basic principles. It's soft, it's squishy, and you can deform it really easily. And when you sort of squish it or apply pressure on it, and then you leave go, it'll come back to where it was, right? That's the big problem with flabby ridges, apart from lack of support and this, that, and the other. But when you have a flabby ridge, and I've seen it many, many times, if you do a regular impression, a regular sort of, even a special tray impression, and you apply pressure to it, and then you take it out, cast it, make a denture on that, that denture 99% will not fit. It won't stay in. So when you have a patient who's got a flabby ridge, you must change your approach, because you need to capture that tissue that is unsupported. You need to capture that in a static position, and you need to continue that through to your final denture. Because if you capture that in anything other than a static position, meaning the same position it is when you just look at it, if you capture that in any sort of compressed position and carry that through to the final denture, your denture will only fit properly when you put it in and push it, because you'll then push the tissue into the same position as what it was when you did your compressive impression. So what I do is, I'll either, on them custom trays, have a window at the front, and I'll put the periphery in, and I'll put the impression in, and I'll do the movements, the big smile, all that kind of thing, and then cut the excess off, put it back in, and then I'll have a look at the flabby ridge itself, and I'll put the windows in big enough so I can physically see it. And if it's just hanging and there's nothing touching it, that's what I'm after. I don't want it to be pushed up on the tray or pushed with a bit of impression material, because it's then distorted. So then what I'll do, I'll basically put the light bodied in the tray, seat that, but I'll not put any around the flabby ridge area so much. And I'll use the window at the front. I'll seat it all, get the patient closed down against the lower. So effectively I've got a big gap here and a big gap there, and I can see the flabby ridge. And then I'll get the little PVS gun and I'll put it in and I'll just pump it. And what it'll do, it'll just flow around the flabby ridge as it's sitting there statically. Because if I sort of compress that or do anything other than record it like that, that denture will just drop. They just don't stay in. And you can reline it as much as you like. You can do it just won't stay in. That's the only way you can kind of accurately record it. If you use the Dr. Arbier technique, then you can use slightly different impression techniques, but they're too long-winded to go in right now. But the aim of them is still to capture the static tissue. That's the main aim of it. So that's how I would do it. Is Facebook transfer mandatory or optional? Can we also use a spring bow and how articulator? Well, you won't have the same equipment if you use Hanau Arctic or spring bow, because everything's been designed to work with each other. Sort of the templates that we set up with have a block which fits onto the articulator. So when you put your the sphere of Monson template with the curve of Wilson and the curve of Spear in the articulator, it's actually mounted on a block which fits onto the articulator, which ensures it's in the correct position according to the Bonwell triangle for setting the teeth up. If you start using like a mix and match approach, then things won't be in exactly the same position. This whole system was designed to work as one. So like face bow, you don't have to use a face bow. I'm just saying if you want to use a face bow, you can take your dentures to the next level. But you don't have to use a face bow. I didn't use a face bow for many years, and I got great results. But I get awesome results when I use a face bow and I do a fully balanced occlusion as well. They are definitely better, but even standard BPS is better than normal sort of processes. So it just really depends, how far you want to take your dentures, really. So it's not mandatory. No, you don't need to use it. It'll work fine if you just use the regular BPS workflow. But if you do want to take it to the next level, I would recommend a face bow. Get some practice in with the regular way, and then if you want to, hit the high notes with the face bow and the fully balanced, then you can do it that technique as well. Okay. I think that's it. Is that everything? Looks like it. What do you reckon, Louise?
Yeah, I think that's it. Thanks so much. Yeah, you did really well. Lots of questions there as well. Yeah.
It's all good, that's all good.
Yeah, Mr. Popular. Thanks so much. And
No problem.
stay safe and hopefully see you soon.
Yeah, same to you guys. Thanks for tuning in. Thanks for your support. And
All right.
I'll maybe see you around one day.
Bye.
Thanks. Bye-bye.